We can get started. All right, Andrew, take us away.
Okay, let's do it. I'm gonna present this a little bit out of the usual kind of order here, just because it was interesting how things developed in real time. So this is a 82-year-old patient I saw who had a history of a remote DVT on Eliquis, previously insulin-dependent diabetes, hypertension, and CKD3, and she came in with chest pain. So her story, she was saying that she was having this left-sided chest pain that was kind of worse when she lied on her left side on and off for the past week. And it was like mildly uncomfortable, but new, so concerning for her. And then she was also starting to feel just more and more winded, like walking around the house, like usually able to go out to the mailbox and, take care of herself just fine at home. But was definitely feeling like more tired, which was okay, but new for her and concerning. And then kind of what tipped her over the edge to come to the hospital was she woke up feeling acutely short of breath at like 4 in the morning, and she felt like she couldn't, keep up with that breathing. So she decided to come to the hospital. So I think it's a good first stopping point.
Awesome. It's just a super, super interesting place to start. And I think, one of the things that I think is standing out here is that there's both a very prominent background as well as a very prominent foreground. And I think I will oftentimes find that those can be challenging moments from a reasoning perspective in terms of what we start to prioritize when we're thinking about building a differential or building a framework here. And I think on the one hand, right, we have this sort of recent development of left-sided chest pain, worse when lying on that side, a sort of background of some exertional dyspnea. But then there's this more acute crescendoing shortness of breath that started this morning. And I think it can be tempting to pull towards piecing all of this together right now and say, okay, we're going to frame this as a sort of subacute cardiopulmonary syndrome. But I think more and more as time has gone on, I feel like I have tried to push myself to say focus on the thing that is the most glaring and the most severe up front, and really shine the spotlight there, and then use everything else to sort of cast a shadow or modify what that spotlight could be. And so in this case here, right, the spotlight deserves to be on acute onset shortness of breath. And if we think about that framework, there are so many different ways to approach shortness of breath, whether you want to use the dyspnea pyramid or one of the other frameworks. The one that I find myself using, I think, the most often clinically is just sort of breaking it down into cardiac causes, pulmonary causes, and then the 3As. And the 3As being anemia, acidosis, and anxiety as a diagnosis of exclusion. But really, right, in the setting of somebody who has acute onset shortness of breath, the focus ends up being on cardiac causes and pulmonary causes, whether those cardiac causes are things like ACS, pericardial disease like tamponade, or aortic pathology, or pulmonary causes being anything from pneumonia to pneumothorax to PE. Heart failure is another one, obviously, that becomes a big part of the cardiac causes of shortness of breath too. And I find that distinction ends up being helpful because we can use so many clues from the history and from the exam to help frame the probabilities of those. Most of the cardiac causes are going to come with a specific syndrome, and that syndrome is usually going to be one of angina or one of heart failure, right? So there's a syndrome of volume overload coming along with it. Whereas the pulmonary causes, more often than not, will have some syndrome of inflammation associated with it, whether it's fevers and sputum production in the setting of pneumonia, maybe a recent inflammatory illness that could bring up the possibility of a pleural effusion or something else in that picture. And then if somebody has no signature of volume overload, no signature of angina, no signature of systemic inflammation, and there's no symptoms really localizing to the lungs like cough and sputum production, then all of a sudden one of those 3As becomes a priority. So if we sort of layer on that general framework onto this, I think we have a couple features here, right? The left-sided chest pain that's worse when lying on that side, I think I'm translating that to say that maybe there's something that something within the pleural space that almost gets moved to that side when she lies on that side. So a layering pleural effusion might feel worse when somebody lies on the side that the pleural effusion is there The other thing is that if we think about when we lie to the side, many of the mediastinal structures shift. So if there's a pericardial process, that could also be happening here. And then certainly musculoskeletal pathology when they bear more weight when from gravity when we lie on that side, that could also be there. But all of those things, I think, come second to the much more sinister hypothesis, which is that these episodes of left-sided chest pain were sort of the canary in the coal mine for what could be now an acute coronary syndrome. We know that shortness of breath can be an anginal equivalent in individuals, and particularly somebody who is older, assigned female sex at birth. There may be an increase or a higher probability that this person may have an atypical anginal presentation that may not have chest pain as a predominant syndrome, and actually shortness of breath may be the equivalent here. So from like a sequence of events perspective, seeing this person in the emergency room, I think I would prioritize some of those life-threatening cardiopulmonary causes up front, really paying close attention to the possibility of acute coronary syndrome. And if those hypotheses are at least falsified or the probability of them is decreased up front, then I think we can turn our attention to using some of this background information, like the ways in which the pain, the character of the pain changes when she's lying down. And I think for me, that would say pleural processes, mediastinal processes, and musculoskeletal processes.
That was beautiful, Jack.
Oh, thanks, Andrew.
Yeah, I love that so much. Okay, let me give you a little bit more information. So she presented afebrile with rates in the 100s, and her blood pressures were 100 to 130s over 70s, and she was saturating 95% on 2 liters of nasal cannula. She had an EKG that showed normal sinus rhythm, no evidence of MI. And on exam, she looked comfortable lying still. She was sitting upright in bed, no icterus on head neck exam. And I didn't appreciate JVD on her with her lying at like 30 degrees in the bed. Her heart sounds were distant as well as her breath sounds posteriorly. I couldn't hear any crackles on her throughout all of the lung fields posteriorly. Her abdomen, she did not have any hepatomegaly or tenderness in the right upper quadrant. She was fully oriented on neuro exam, no gross deficits, and then she had pitting edema, like 1+ to like the mid shins bilaterally. And for labs, I'll just give you the remarkable ones. She had a mild hyponatremia to 135, an AKI with a creatinine of 2.1 from 1.3. She had some azotemia with a BUN of 46 from 32. She had normal LFTs, no prior NT pro BNP, but the BNP was 1070, which was high. Her tropes were 23 downtrending to 14. She did not have any leukocytosis. She had a stable normocytic anemia. And we got this initial chest x-ray on her. Let me try and share it for you all. If I could just have co-host, whoever's leading the meeting, that'd be awesome. Thank you.
I got you, Andrew. Give me one sec here.
Thanks, Jack. And then Noah missed the trope. The tropes were like 20 downtrending to like 13, something like that. Okay, thanks, Jack. This was the initial chest x-ray for her.
Whew.
And this is AP chest x-ray with her like down in the ED.
Okay. All right. All right. So really, really rich information here. Andrew, just to make sure for the troponin, is this the high sensitivity troponin?
Yeah. So this is like nanograms per liter, if I remember.
Okay.
Yeah.
Okay.
This is like only mildly positive.
A touch, like a 0.02 on the old scale. Okay. Right on. So I think, I think there's two things to focus on here, which is one is to say, okay, what is the primary syndrome that's emerging here? And then we can start to pull in some of these different elements of her past medical history and helping us frame the primary syndrome that we have here. I think first things first, what jumps out to me in the vital signs, but there's some low level, or I shouldn't say low level. I will say I am curious about the possibility of a relative hypotension. That is to say that this is somebody who has stage 3 CKD and carries a diagnosis of hypertension. I don't necessarily see antihypertensive medications on her medication list. And I think that brings up two things. One is that this hypertension is no longer a problem and she no longer needs meds, or that maybe this is somebody who actually hasn't had effective management of her hypertension yet, and that may make her more likely to be somebody who would probably be hanging out in a more hypertensive zone. And so when I see those two things together, I would expect her to have a much higher baseline blood pressure than the hundreds over the 70s. And so I think I'm interpreting that as sort of saying, okay, maybe we're dealing with a component of relative hypotension here. And then it seems like we also have potentially some low-level hypoxemia. It is not atypical for people to get thrown on a touch of oxygen when they come into the emergency room or come into the hospital. But I think we can, looking at that chest x-ray, we certainly see reasons for her to have some component of hypoxemia. And so it seems like we have a component of an oxygen requirement here. And then if we start to look at the exam, I think we get some mixed pieces of information here, right? We said that when we're thinking about causes of sort of abrupt shortness of breath, we want to think about cardiac causes, which can come with a syndrome of volume overload or angina. And looking at this exam, there's some mixed evidence here of whether or not there is volume overload. On the one hand, we have pitting edema that's 1+ to the mid shins. There's no significant JVP though. And I would say if I'm going to put those two together, I think I tend to put more weight in my detection of lower extremity edema than the JVP. You all may be much better at the JVP exam than I am, but when I see it, it's super helpful. But when I don't appreciate it, there are many reasons that I may not see it beyond the fact that the person isn't volume overloaded. And so, Andrew, I know I suspect that you have much more adroit physical exam skills than I do. And I think, right, don't want to say that the absence of JVP doesn't mean that there's volume overload, because it's just one piece of data that we use in getting the overall assessment of volume status. So I think what the exam and the blood pressure, or I should say the exam and the vitals are doing, is they're starting to paint a picture of a possibility of maybe some syndrome of volume overload. And then we have two other pieces of data to bring in, which is the distant heart sounds, and then that really enlarged cardiac silhouette on chest x-ray. The most common cause of somebody having an enlarged cardiac silhouette on chest x-ray is that their actual whole myocardium is just enlarged. There's a component of a dilated cardiomyopathy, or a component of an enlarged heart in the setting of increased filling pressures into the heart chambers. So that is one hypothesis, is that what we are dealing with is just a sort of typical syndrome of heart failure. And I think the elevated BNP supports that as well. But the other possibility here is that what we're actually dealing with the distant heart sounds is that this isn't actually necessarily a problem with the myocardium, but potentially a problem in the pericardial space. Because if the heart gets enlarged, it can give you an enlarged cardiac silhouette, but also if that pericardial space fills up with fluid, that can also give us an enlarged cardiac silhouette on chest x-ray as well. So this I think is I would say POCUS. We know from many of the VMRs with Ravi and team how valuable POCUS can be. I think that this is a situation where POCUS becomes especially valuable. One, it can give us another piece of data looking at the IVC to clarify our volume status. If that IVC is dilated and non-collapsing, that further supports the volume overload hypothesis or the increased cardiac filling pressures hypothesis. And then we can also get a quick view and look at the pericardial space and see, is there a large pericardial effusion or not? That becomes important to know, because if we're querying the possibility of tamponade physiology developing, right, worsening pulmonary edema, worsening blood pressures in the setting of a pericardial process, we would actually not want to diurese this person up front, but we would actually want to give her a little bit of volume to temporize her until something can happen with the pericardial space. I would say the one other thing lingering in the background that I saw somebody brought up in the chat is that the whole cardiac process could be a bit of a fake out. And when we see hypotension, new oxygen requirement, and some component of pleurisy in someone who has had a DVT in the past, PE comes to mind. So I think I'm keeping that in the background right now for two reasons. One is that we have every reason to believe that she has been effectively anticoagulated with Eliquis, but also the predominant syndrome here, if we think about all of the data, what seems to be pulmonary edema, an enlarged cardiac silhouette, some lower extremity edema, a very high BNP, and some renal dysfunction, paints a picture of some sort of volume overload syndrome. And I think the crux there is that poor cardiac function and decompensated heart failure coming from the myocardium not working well, or the pericardium and the pericardial space being on the hook?
All right, let's give you the final aliquot, Jack. So what happens to this patient? So being authentic, I saw I left out she was on some antihypertensive meds.
Okay, right on.
So I thought multiple cardiovascular risk factors, wet chest X-ray. I felt very confidently this was probable like HFpEF, and like echoes pending for like 24 hours. Do not catch this potential enlarged cardiac silhouette. So we diurese her over 24 hours and she feels better. So she goes to the floor and she feels less dyspneic lying flat and she's doing okay. And then just sharing my screen again here. So this is her vitals trend. On the floor, she started to have some atrial fibrillation with rapid ventricular response, which we rate controlled during the day just fine, started PO metoprolol, and you can see that she's doing okay. So I go home and I come back, and in the morning, the overnight hospitals was actively trying to rate control some rapid ventricular response again, and her blood pressures were a little bit lower now, more like in the 90s range over 80s or 70s here. And I give 5 IV metoprolol 3 times without any effects. I up-titrated the PO metoprolol without any effects really. I moved on to IV diltiazem, hitting like the 0.25 mg per kg dose. And I had some transient effects, but then she started to go into RVR again. And that's when her echo results comes back and the final diagnosis is revealed.
All right. Interesting. So Andrew, just to make sure that I have the sequence of events well, a little bit of diuresis, a little bit of rate control, and then had a recurrence of AFib with RVR that was essentially refractory to rate control in that moment. Okay, awesome. So I appreciate the clue that the echo results could potentially, or that the echo results give the answer here. I think in this context that we're dealing with, which is AFib that is refractory to rate control, I think what that usually signals to me is that there is a very, very, very high sympathetic hyperactivity happening here. So if we can't get somebody's RVR under control, despite multiple doses of medication, there is probably some sort of sympathetic surge that's happening that's really driving this person's rates up. And it's really, really difficult to beta block somebody through or to calcium channel block somebody over very, very high adrenergic tone, right? That is just the body's compensatory responses saying, I win, I need this heart rate to sustain cardiac output. And I think so looking at that, I think what that tells me is that if we think about cardiac output is a component of heart rate, stroke volume, and MAP, right? If her heart rate is very, very high and difficult to come down, then it maybe signals that she needs that heart rate to maintain an adequate stroke volume here. And looking at that blood pressure trend, it seems like that may be actually getting harder and harder for her to maintain overall. So then I think the question becomes, why is the stroke volume high? Or why is the stroke volume so low? Is it low because the myocardium is depressed or because the pericardium is depressed? And I think my gestalt here is, or I think this is where the background comes into play. And I'm really, I think, torn by the base rate of disease would say this is heart failure until proven otherwise. So epidemiologically, I think would say that there is no reason to suspect that this is not run-of-the-mill HFrEF just based off of the base rates alone. But I am sort of tempted by some of these peaches in the past medical or in the background here, which is that there was some left-sided chest pain that was worse when she was lying on her side. That could be, right, angina related, but it sounds like we haven't had dynamic EKG changes and the troponin trend wasn't super exciting. But there could have been an infarct in the past that had happened, and heart failure can have maybe some pain, but I would say that's very, very atypical. So I think that, to me, the sort of pain when she lies on her side signals to me maybe that there's a positional component to the chest pain, which I think invokes my illness script for pericardial disease, or I think classically pericarditis, but also certainly an inflammatory pericardial effusion. So I think, like, from a base rate perspective, I'm going to say that that we're dealing with probably a reduced EF, just from, exactly as you were saying, Andrew, heart failure and HFpEF. But I think the possibility of a pericardial process is quite high, given some of these pieces of data that we have in terms of the positional component of the pain, and then that very, very enlarged cardiac silhouette on chest X-ray. And the fact that diuresis may have challenged challenged her cardiac output in a way that she wasn't able to continue to compensate for.
All right, Jack, and great work with the discussion. Everyone in the chat was on this right from the beginning. Wish I could say I was with you, like, in the diagnostic journey, because what happened was I got a phone call from Echo saying this patient has a moderate size pericardial effusion with signs of tamponade, and I had both the moments of, like, clarity and awe, like, it all makes sense in retrospect now. I thought it was weird I couldn't hear her heart sounds at first, but it didn't prompt me to go grab an ultrasound or anything like that. I did feel this was just like HFpEF at first. I just didn't make that next step. And then I had a moment of panic when I realized we had been diuresing her over the past 24 hours and she was basically spiking these heart rate responses. So we got a bag of lactated ringers at the bedside immediately, gave her 500 cc's LR. Cardiology was there immediately, and she ended up getting a pericardiocentesis. And on further history, she had apparently like a viral URA type illness a couple weeks prior. So I think the most likely diagnosis is she had some sort of pericarditis that caused this, but of course we're still waiting on an answer. But yeah, I'm never going to forget this case because everything in retrospect seemed very obvious, but yeah, I don't know. It's weird. I think base rate can really trip you up, and I don't think about tamponade for new CHF. It's just not really something super high on my list. So yeah, those are just kind of my shotgun thoughts from this past week.
Andrew, I could not agree with you more, and I feel that sting in this moment, which is, I can't tell you how many times this has happened to me where I feel like I'm like, I have this case that where I bring it to a case conference setting. I'm like, I struggled so much, there's going to be so many dilemmas, and then at some point in the first aliquot, someone's like, this sounds like a peritonsillar abscess. And I'm like, I didn't realize it was a peritonsillar abscess until day 5 of their hospitalization. Like, how did you find it after one sentence? And I think one of my reflections on this is that just by virtue of the fact that it's coming to the case conference setting, right, my brain is primed to be like, this may just be run-of-the-mill heart failure, but the base rates here are different than the base rates in clinical practice. And then the other thing is that I am contending with a fraction of all the other things that you're contending with in the clinical setting, right? This can be billed as, this is somebody who has heart failure, and we have no reason to suspect it's not just run-of-the-mill heart failure. There's no real clear signature of any sort of pericardial process other than the history, which I imagine, knowing you filtered down so eloquently to allow us to think through and to process. And so, like, the data that we get here, it's filtered and packaged in a way that doesn't necessarily reflect all of the things that we have to contend with in practice, let alone other things that you're having to do, orders that we're having to put in. And so I think, like, the content may be there, but how the content manifests in context is so different here versus in the real clinical setting. And those contextual factors play a huge role in how we think and how we reason. And so, if anything, right, this, I hope, validates the fact that you just alley-ooped all of us here. Because I think if I were to be off, like, if I was with you up front, I think there's nothing that says that this is not a typical decompensated heart failure until there is the response to empiric therapy that is maybe unexpected to how we would plan things to go. Like even that chest X-ray, right? Like cardiomegaly on chest X-ray is totally compatible with a heart failure illness script. So I think this is like for everybody, it's such a valuable part of bringing cases here that it gives us a chance to reflect and learn together. And that feeling of when everything clicks 2 days in, or like when it would be helpful for things to have clicked when we were admitting them rather than a few days in. I feel your pain on that. If you can find a way for learning to happen without that feeling, please let me know, because I would love to figure that out. But oftentimes I feel like the ones where I feel that is oftentimes they are the most educational overall. Yeah, but yeah, thank you for bringing this. Please keep us posted if there's anything else that comes back on what the tamponade is from, or what the pericardial disease is from.
Yeah, absolutely. And I guess just one last thing before we close out. Yeah, Avi said in the chat, I too can never fully trust the finding of dissonant heart sounds on exam. Actually, I think that's something subconsciously that I did, actually, that I'm just not recognizing. Is there are a lot of patients where you can't hear their heart sound just because of their body habitus. And I think I had translated that to her in this case, because yeah, this is the first time I've heard dissonant heart sounds where it's truly due to fluid in between rather than something else. But anyway, I'll pass it off to whoever's going to close us out.
Okay, guys, so let me take you real quick through the teaching points. Amazing discussion, an amazing case, and even greater reflection at the end. So I really loved it. So basically we started with a patient that had subacute chest pain and also subacute dyspnea that later got worsened. So every time we get chest pain on a clinical picture, we should always rule out the emergent causes, and we used the 4+2+2 mnemonic for that. Remember that the 4 is for the cardiac causes like ACS, aortic dissection, tamponade, and Takotsubo cardiomyopathy. The first 2 is to rule out pulmonary causes such as pulmonary embolism and pneumothorax, and the other 2 are to rule out esophageal causes such as esophageal rupture or perforation. So in this patient, we had basically 2 concerns that maybe could correlate at the clinical picture, but we should ask the question, what is the primary syndrome that this patient has, or are these 2 findings or chief concerns correlated? Basically, we could confirm that these 2 were correlated, but we shift our focus at the start to shortness of breath. So what is a good differential for shortness of breath and how we should tackle it? So every time we think about shortness of breath, we must think about cardiac causes, pulmonary causes, and the 3 A's, such as anemia, anxiety, and acidosis. From the clinical picture of this patient from the start, we suspected more some of cardiac and pulmonary causes rather than the 3 A's. Later in the history, we obtained that this patient had chest pain that was worse with the positional change, and this made us think about either pleural, pericardial, mediastinal, or musculoskeletal disease. But we also took into consideration that we had data before that this patient had risk factors for pericardial disease or acute coronary syndrome, and we used that in key to narrow down our differential to either a cardiac cause or a pleural mediastinal cause. So in this patient, a good point that Jack made was that angina doesn't necessarily present as chest pain, and this is even more true in elderly patients and women patients. So this patient presented with also shortness of breath, and shortness of breath in these kind of patients is also an equivalent of chest pain in angina. Also, this patient in the physical exam, we got that she got a blood pressure of 100/70, and with her previous history of chronic kidney disease and hypertension, that made us suspect that of possible relative hypotension, as we suspect that these kind of patients have higher blood pressure readings. Also, she was having a saturation of oxygen of 95% on 2 liters of oxygen. So that was a little bit low considering she was on supplemental oxygen too. Later, we got a chest X-ray, and it gave us some kind of data that was important to the clinical presentation of this patient. So she had distant heart sounds, and also she had enlarged cardiac silhouette in the chest X-ray. So when we see these two together, we must think about either a problem with the myocardium. Um, this means like heart failure or dilated cardiomyopathy, or we must shift our focus to a pericardial disease, such as effusion or inflammation into the pericardium. This is when the POCUS or echocardiography comes in key to make a differential and narrow it. So that makes us, that can allow us to see the filling pressures, the V can allow us to take a shot at the pericardium and also to see the ejection fraction to differentiate between either is this a pericardial disease or is it a myocardial disease. So later when we obtained the echo results, we saw that this patient had a moderate sized pericardial effusion with size of tamponade. So basically it really gave us the diagnosis just with one test. So later we were talking about some reflections, and I really love what everyone said in here. So the reflection that I took home is that we always need to take into consideration what is the baseline status with the patient and correlate it with the disease, and also take into consideration what this patient has to avoid a premature closure, such as Yusuf said in the management reason in VMR last week. So that's what I have for you guys, and thank you.
Thank you so much, Marino. That was, yeah, absolutely phenomenal summary. You're getting a lot of love and shout outs in the chat. And Andrew, I can't thank you again for bringing this for us all to learn from. I think preparing a case like this is always takes a ton of effort. But also, I just want to say I really admire the authenticity and the openness that you shared in walking through both how it played out for you and then also the personal learning points from it. I think it's I'm walking away from it feeling really inspired by the way that you're doing that, and I think it's motivating me to think about ways to bring that into the teaching and learning space overall. Because I think to share, to create an opportunity for all of us to learn from the moments that you've learned from is like teaching at its finest. So I just want to say thank you for doing that today, and thanks everybody for joining us on this Wednesday session. I hope everyone has a great rest of the day, a great rest of the week, and we'll see you soon. Take care, y'all.
Bye, everybody.